I am Luciana, and it feels really emotional to be here because I was here 7 years ago, and I was in a very different place. My daughter was in a very different place. So thank you for this community, and thank you for working so hard to keep our kids well. Okay, so is it this one? Yeah. So this is Beatrice, and she has her bone cake, so 6 years after BMT. Yeah, she's away from me. She's studying in California. So she was diagnosed in 2013. I'm not going like a lot into her story because I've told before. So I want to give like a little bit of the BMT perspective about the criteria and other things. But she was a very refractory patient or difficult to treat. And she had quite a few episodes of MIS, liver reaction, lung disease, and then it evolved very fast to pulmonary hypertension in her case. We were living in Switzerland, so the BMT was made in Switzerland. She had some bumps, but bumps are normal in BMT. And yeah, she's doing great. She's in remission, just calcium, vitamin D, and birth control pills. Because she's an adult now, so yeah, birth control pills. Yeah, and she used all the meds that are here, and she is really in complete remission. And since then, since 2018, I'm in the Facebook group, and I've been talking to the parents who are being evaluated for BMT. So we are like a really close community. So whenever someone is talking about BMT, Leah tags me or Hashmi tags me, and then we are close to these parents. And there are like lots of things when you make a decision to go to a BMT, and it should be a shared decision because BMT is not easy. Even when it goes well, it's not easy. It's not an easy treatment. So we did this decision. For us, back in 2018, it felt like we had no other choice because there were no JAKs, but we have JAKs now. So, and now, where do you decide to do the evaluation for a BMT? What we are seeing is that different centers are making this in different times. Like some centers are trying JAKs, some others are not. Some countries, we do have IL-1, in others, we don't. So it can be tricky. What we used to say is that being evaluated for BMT doesn't hurt. It's not that I'm saying that everyone should be or that I'm defending. No, but it's another treatment option for the difficult to treat patients. Yeah, and we didn't have a 10 out of 10 match. It was a 9 out of 10 match. And she was also positive for the HLA-DRB 1*15. So, and that's why we decide. And we are kind of seeing also these patients, some are positive, some are not, some in Europe, some are having like a drop in chimerism, but it's still in remission. Some have high chimerism and are not in remission. So, yeah, so it's really very, very diverse. So I would like to start this is Pierre Cartier, all of you know this paper. And then here we can see that in his recent approach, he's kind of mentioning BMT in almost all the phenotypes, all the different patients. Okay. And okay, so last, that's what I told like at least 9 BMT. So I know like 2 in England, 1 more in Switzerland, a couple in Cincinnati, some in California. So that's the patients we have been talking to. All of them, I think they had MIS episodes. And but what we are thinking is that before it was just the lung disease patients, and now we are kind of seeing patients with other phenotypes like the persistent arthritis and also the patients with the GI issues. So as a parent, can we have a kind of algorithm or can we know when is our window of opportunity to go for a BMT? Because if like the damage is too far, then we cannot go. Even for us, so Beatrice had pulmonary hypertension. She had to do a catheterization 1 week before BMT. So if it was like a high pulmonary hypertension, then it was a no-go, but it was a mild one. But then you have all these emotions there, right? Like 1 week before BMT, and maybe it's a no-go, and then just treated with dexamethasone. So, yeah. So with that, this is my question. Is it possible to have an algorithm or protocol for BMT evaluation in sJIA, MIS in refractory cases? Thank you.
With that, Dr. Marsh.
All right, I'm going to wait for my slides. I know they have them. I double-checked because I'm that person. First, I'll just thank Rashmi for inviting me. I actually met Rashmi many years ago now. I was involved in the care of her son, and their journey has been an inspiration to many of us in the room, as you well know. So thank you for inviting me and involving me. So
I think we actually met at either 2016 or 17 NextGen.
I think that's probably true. And maybe Alexi is the one who invited me, now that I think back on it, actually. Yeah. All right. So I'm going to start us off in the evening slump with the medical portion of this session. And I just wanted to spend my 10 minutes talking about a very high level of bone marrow transplant and how does it work and when can it be considered. And then at the end of the session, that's when we'll have some fun, sort of debating when you should or shouldn't think about doing this in patients with sJIA. So just some disclosures. I am employed part-time by Farming Healthcare and part-time at Cincinnati Children's, but none of these things has anything to do with what we're talking about today. So, and I'll apologize because I failed to find a good rheumatology joke to open with, and I really like to do that when I give a talk, but they were just all too inflammatory. It's pretty good, right? All right. So BMT, how does it work? So just to set us all on the same page for those of us who aren't transplanters, a bone marrow transplant for today means the same thing as a hematopoietic cell transplant, which means the same thing as a stem cell transplant. I could throw cord blood up here and other things. Today, we're just talking about the process as a whole. Allogenic transplant means that you take stem cells from a donor, you remove them, maybe you process them, maybe you don't, you give them to another patient. Autologous is when you take stem cells from a patient, you remove them for a period of time so that the patient can get therapy that's very toxic, then you give those cells back to them. So these are two different types of procedures. This is all I'm going to say about this. I'm going to move on now and I'm going to talk about allogeneic transplant, where we're giving donor stem cells to a patient. And really, transplant is sort of like planting a garden. And this is not my analogy. Transplanters use this analogy, but I really love it. It speaks to me. How is it like planting a garden? First, as you guys know who do some gardening, you have to make room for your garden. How do you make room for your garden? You go and kill everything that's already there, right? Like, it's kind of mean. You kill everything that's there so you can plant your tomatoes and your peppers and your yada yada. So you got to make room with some sort of toxicity to what's already living there. Those are chemotherapy. Then you have to plant the seeds. What are the seeds? Those are our stem cells. What do you have to do after that? You have to wait. You have to nurture those new plants. You have to give them water, sun, food, love, of course. You have to keep harmful things away, like the deer. And at some point, those new plants will be able to survive on their own. And so when we think about a transplant, how can we make it similar to this analogy? So we're going to go through the process. We're going to talk patient, donor, conditioning, graft, and recovery. Simple. Allogeneic bone marrow transplant in inborn errors of immunity or systemic JIA in immune disorders. So which patients are appropriate to consider for transplants? This is a very important question, always, particularly important for this group. So number one, The disease needs to be caused by a genetic disorder, whether that's a known genetic disorder that someone's discovered and you can test for and you can put your finger on. Or in our world, we transplant patients with immune disorders that we don't have a genetic disorder that we can put our finger on. But I will tell you, there's probably a portion of patients with sJIA, MAS, and lung disease that have some underlying disorder that will be discovered someday. And really the point of this is that it needs to be something that's wrong with the immune system. And it can be only a problem with the immune system, or it needs to be a problem that's predominantly caused by some problem in the immune system that's causing immune dysregulation and too much inflammation and damage to the patient's tissues. So that's really the point of that. We have to think about making sure that patients have disorders that affect predominantly or only their immune system. Because when you do a bone marrow transplant, you're only replacing the immune system. You're not replacing new lung tissue. You may have new lung tissue that grows as patients age, et cetera, but we're only replacing that immune system. And as transplanters, we have a very high threshold for who we consider for transplant. There has to be a significant risk of morbidity, so lots of problems, and mortality, meaning death, associated with the underlying condition, because transplant has a risk. And I typically tell patients that come to clinic, for all comers, survival is 80%. And that sounds sort of good, but if you put up one hand, what's the risk of dying? It's 1 in 5. This is a lot, right? There's a lot more room to go before we're helping even more patients. So those are 2 points there. It's a lot to balance in these conversations. I can tell you at Children's, Grant, Alexi, Sharat, and I, our other colleagues, we have a lot of conversations about these patients because we're always trying to make sure we tried everything else we could for these patients. And like you just heard, making the decision to transplant before it's too late. So we're always balancing, and things that go into that are, what are the donor options for a patient? Is there a sibling? Is there a full match? Are there new clinical therapies that have just become available that we want to pause and think about trying? How is the patient doing all the time in response to other treatments they're on? Lots of things go into this. All right. So once you've made a decision, you're going to find a donor. It's like playing memory. Who played memory when you were little? Right? It's a fun game. So how is finding a donor like playing a game of memory? So HLA typing. So HLA, these are molecules, MHC class 1 and class 2 molecules that are on immune system cells. These basically let the immune system talk to each other, okay? And those molecules are encoded in your DNA, so you inherit them. Sometimes those immune system signals between a donor and a patient are good. Everything's happy. Sometimes they're not good. Sometimes a donor's immune system can recognize a patient's immune system as being foreign and different, cause a lot of problems called graft versus host disease. And this is a big problem after transplant. It remains the biggest barrier still to transplant when that immune system recognizes the patient and causes tissue damage in the GI tract, the skin, the liver, the eyes, the lungs, everywhere. So you sometimes with a transplant, you do trade one problem for another. So that's why we try our best to prevent graft versus host disease. This is why it's like memory. We are very fortunate at Cincinnati Children's. We have wonderful search coordinators. They do all the hard work for us, looking through all the different databases, looking through the NMDP database, and we're just looking for all of the different HLA genes to match. So you can see this patient and donor, do all the numbers match? They all match. So this is a great fully matched donor for this patient. So once we've done that, there's typically a good chance, especially if you're Caucasian, that we will be able to find a fully matched donor. It's the minority of cases in minority populations. So the probability of finding a perfect match does vary based on your background. Step 3, conditioning regimen. There's no time to talk about all the nuances for conditioning regimen, but for the families in the room, it can be very anxiety-provoking to talk to 2 or 3 different transplant centers who might use different conditioning approaches. And so what I like to say about this is it's sort of like transplant centers are like bakeries. And as long as you're at a reputable center, they're going to have their own recipe for cake. And I don't know who would prefer chocolate icing on yellow cake versus the others. Anyone? I would, because that's what my mom made me when I was little for my birthday. Rainbow cake. Takers, got a couple. All right, cheesecake. People are holding up for cheesecake. Lots of cheesecake. All right, so this is the difference. These are all 3 delicious cakes, right? So if you're at Cincinnati Children's, if you're at Philadelphia, if you're at Great Ormond Street, you might get various combinations of chemotherapy and serotherapy, and we're not going to talk about them, but in general, it's really just variations on recipes on treatments. Step 4A, stem cell collection. We can get stem cells from the bone marrow. We can get a frozen cord blood product. We can collect through a procedure collecting stem cells from the peripheral blood called apheresis, and that's what you see on the right. Give those stem cells to our patient. And then it's really recovery and time and waiting for that bone marrow with new stem cells to produce all the new immune system cells. And so with that, I'm going to say thank you, and I'm going to turn it over to some of my colleagues to talk with more details about bone marrow transplant and experience in sJIA. So Jim, I think you are next. Don't trip on that cord. It almost happened.
All right, thanks, Rebecca, for that. I always learn from you whenever you talk, even when you're talking about the basics of transplant. I'm going to use that cake analogy. I love it. I'm not sure what we have at Vanderbilt, but I'm definitely a chocolate cake fan. Just wanted to, again, thank this really amazing conference that's here. I think I've really unique. I've been to a lot of both academic conferences and family conferences, and I think this really stands out. So again, thank you. And really as part of, I think, what this session is really going to highlight is the need for rheumatologists and transplanters to really communicate better. So we can learn from you, you can learn from us, we can learn from the families, and all come together to really kind of answer these tough questions, or at least come up with an approach of how we can hopefully answer these questions in the future. So I'm going to talk just a little bit more generally about the importance of the immune system after transplant. This is an area that I'm very interested in and have really begun to research over the past couple of years, and why this is, when we think, Rebecca kind of mentioned that, there's going to be some different recipes there, but they all work well at their own institution. And trust me, if you're very good at making a chocolate cake, you don't want to try to make the rainbow cake. That's why often when we have those discussions, we don't say you need to totally pick a new recipe. But I think where we can get, some of that uniformity is how we think about these patients. What are the things we need to follow so that if you're making a chocolate cake and I'm making a rainbow cake, that we can actually compare those outcomes because we're measuring the same things. And part of that is going to be immune reconstitution. All right. So I'm not going to go through too much into this slide because of the short amount of time that I can. But this is just a really just general overview of how we think about immune reconstitution. And all of those, this is not my figure, but all of those kind of baby blue boxes, if it's the same color, on the television screens here are kind of all the factors that are important of how the immune system is going to recover afterwards. And as you can see, it's incredibly variable. And again, conditioning is one of those things that are variable, but so many other factors. And I think as a little bit of data that we have in sJIA, certainly the underlying disease is going to have a huge impact on how your immune system is going to recover. And so that's one thing I wanted to point out in this slide. And then I think the other one is that not everything comes back all at once, of course. So, we're trying to rebuild an immune system, and there are certain pieces that are going to come back fairly quickly, and some of them which are going to take months. And in fact, if you talk to a lot of transplanters, we think it takes about 2 years to get true functional recovery of the immune system as you kind of go through it. And so when we think about how we can look at immune reconstitution, there's a lot of ways that have been done. And I think one of the difficulty parts that we have as transplanters, particularly working with rare diseases, is that these patients are few and far between, but we also look at them differently. And so again, it makes it difficult sometimes to kind of make good comparisons to really measure outcomes and see what is efficacious in patients. And so when we look at how we can look at immune reconstitution, the most common way is just through immune cell phenotyping. And so this is typically done through your basic flow cytometer to do that. I will say that a lot of immune recovery studies that have been done in transplant have focused on T cells. And it's a little tongue-in-cheek that I called it a transplanter cell. But the reason I do is because for the most part, transplanters, that's where most of their mind is at, because it's the T cell that is really driving a lot of the pathology after transplant, graft versus host disease. But obviously with our diseases that we're talking about here, there's going to be much more variability in other thoughts of other forms of immune reconstitution. Basic immune cell phenotyping, it's available at most centers. And the nice thing is we talked a little bit about chimerism, that'll come up again, is that you are able to kind of sort the cells through a flow sorter, and you can look at what we call split chimerism. So that means looking at the percentage of recipient or donor cells, and when you do split, that means you can look at different populations of cells. So example, a T cell or a myeloid cell. Disadvantage, you have to have cells to do it. And so a lot of the immune reconstitution studies have been done, kind of stochastically, and really done at, often, in my opinion, pretty late time points. A lot happens between day 0 and day 30, but it's not until about day 30 do you actually have enough cells that you can actually start doing some cellular assays. If you want to do advanced phenotyping, that's really expensive and less available. And remember, just because a cell is there doesn't mean that it's functional. It used to be thought that, well, T cells, you can get those to come back and it can take time for them to actually have true function. But we're learning things like neutrophils and monocytes actually also aren't very functional early after transplant. You can look at immune cell function. So this is actually looking, do the cells actually work the way that you'd want them to? And so you can look at the response to specific infectious antigens. CMV is a common one. Again, a disadvantage, less available at many centers. And of course, you have to have memory cells that are there for you to look at the antigen of interest. Transcriptome, so basically this is looking at when you take your genes, so you take the genome of the cell or of the patient, if you're doing a bulk analysis, and seeing how those genes are being read and made copies of them and what are called transcripts. And so the nice thing about this, if you do this across the whole exome, you really get large amounts of genetic expression data. And you can even get that if you sort the cells initially at the single cell level, which again gets quite expensive. And so that's really the big disadvantage. And a lot of these things will come is that you can definitely look at some of these kind of inflammatory gene transcripts that are there. But understanding in transplant is inflammation good or bad is really going to be important. And so in order for this data to become really valuable, we're going to have to really do lots of patients to do that. What might be really important, because this is where a lot of the discussions have been, is the secretome. So this is what a lot of the discussion has been. And surprisingly, we as transplanters have not really looked at it. I think Cincinnati is one of the centers that's really leading this and looking at these cytokines and chemokines and how they are important for both good and bad inflammation after transplant. So advantages is it's fairly inexpensive. On our research platform, we can do a multiplex assay for about $58, which in the research world is pennies. It can be conducted early on, so even before cellular recovery. And where this could be an advantage or disadvantage is that looking at the secretome may be very important for certain diseases, such as the diseases we've been talking about here. Of course, as I think a lot of us know, some of these assays aren't very sensitive for looking at certain cytokines. And again, you could look at it as good or bad, is that certain cytokines might be important for particular diseases, but not all diseases. Chimerism is another way to look at this. This is where you, again, looking at what % of the cells are donor versus recipient. This is completely done on genomic data, meaning that you actually have to get the DNA out of the cells, which does have some limitations as far as if you can really look at different cell populations with that. It's found to be very good for predicting relapse and malignancy, and for some non-malignant disorders, demonstrating disease remission. But certainly in this very, and in my opinion, the most complicated set of disorders to transplant are these immune dysregulatory disorders, which includes sJIA, is that the chimerism may not be as predictive as it is for other disorders. And I think that's already been mentioned, and we'll talk a little bit more about that. And is typically limited to kind of common markers of myeloid and T cells. Lots of limitations to date. Again, most of it has been done on peripheral blood with focus on T cells. the immune system recovery is very dynamic, but often we're only getting these very infrequent time points to take a look at these snapshots. I already mentioned that it's hard to tell donor versus recipient immune reconstitution versus in non-genetic measures. Often we do these studies on large cohorts with variable disease and transplant approaches. And so again, when you're working with non-malignant disorders, there are so many things that go into immune reconstitution. It can be really hard to tease out outcomes in those settings. And as I mentioned, this gets more complicated with smaller patient groups because some of those variables are hard to divide between the two groups if you have just small groups of patients that are there. So why is it important? So again, most of this work has been done in T-cell recovery. And so a lot of this work has actually been done in Utrecht and has been done with collaboration within the US. And this is one of their papers actually looking at, again, where a lot of the focus has been, and not just on T-cell, but in particular CD4 T-cells. So that's one of the major subsets of T-cells that are out there. Part of the reason is that CD8 cells are actually quite variable in the transplant process. So if you get infections or other stimuli to the immune system, CD8 cells seem to respond quite wildly compared to some of the other subsets. But as you can see here, this is their most recent paper when they looked at non-relapse mortality. So that's typically death from graft versus host disease or death from infection. And chronic GVHD. And when I think of non-malignant disorders and I want to look at key outcomes of how transplant's going to help them, obviously survival, does your disease come back, or do we replace that disease with another one? And that other disease is chronic graft versus host disease. So Rebecca mentioned this as graft versus host disease is a common complication. And what we worry about in non-malignant disorders, we might cure their disorder, but replace them with something that in some cases could be worse. And so at least this group showed that if you had a T-cell count greater than 57 and they started looking at B cells greater than 35 at day 100, that the non-relapse mortality, which is in the black line there, is, the green line, which has both CD4 and B cell reconstitution, is best for both non-relapse mortality and extensive graft versus host disease. Hopefully I'm not stealing any of Dr. Silva's thunder, but she, has our most complete paper published to date looking at outcomes in sJIA. And so I did kind of paste some of her immune reconstitution study that's here. So on the left, this is just looking at T-cell recovery. And the reason is I just want to show you, is the recovery we're seeing in sJIA kind of similar or really different than what we see in other conditions? And so the panel on the left are pediatric patients with a wide number of underlying disorders. But this paper, the reason I included this figure is that it does include Campath, which is a common conditioning agent that's used in sJIA, at least in a handful of cases so far. So that's kind of the gray line, the gray dotted line that's there. And as you can see here on the left is that these are T-cell recovery over the course of a year. And when we think about T-cell recovery, there's really kind of two phases. There's an early phase, which is really during the first 3 months, where you kind of get T-cells that are responding by a process known as homeostatic proliferation, which just means that there's a lot of cytokines around, and kind of the threshold for that cell to proliferate is actually much lower because of this large amount of cytokines. And of course, anything that is working through the T-cell receptor through an antigen-driven process. But afterwards, you get thymic production. And so that's kind of the second half of production. So if you compare that on the right, again, these are just a small number of patients in Dr. Silva's paper. But the T-cell recovery is definitely lower, but not significantly lower. One thing that I would point out, however, is that the CD4 reconstitution is really lower. And typically what happens is that the CD8s tend to come back much quicker. But because of thymic reconstitution of the immune system, the CD4s tend to catch up over the kind of latter half of the first year. And so certainly this may be indicative of these patients maybe coming in with incredible thymic dysfunction, which is no doubt because they've been through multiple rounds of immune suppression and had lots of infections, and we know those are particularly damaging for thymus tissue. I think Dr. Silva, I'm sure, will cover this as well, but I really liked how she did this in her paper, where she really kind of illustrated kind of these different forms of chimerism that happens. Again, chimerism is how much donor and how much recipient you have. And so if you're green, you're 100% donor, red, you're 0% donor, and blue, you're somewhere in between. And circles would be myeloid, so those would be things like monocytes and neutrophils in the peripheral blood, and squares are the T cells. And what is quite striking here is I just kind of picked 4 different examples from her paper. And you look at the first patient, 100% chimerism, complete response. Second patient, 100% donor chimerism, partial response. The third patient, 100% donor, relapsed. And then the last patient, which has a tiny, tiny amount of donor cells, complete remission. So it just begs to the point, is why is this happening, right? That's not what we tend to think about as transplanters. It's like we give each other high fives when we see the 100% chimerism come back. But unlike the majority of disorders we transplant, there's clearly other things going on. So that's a big question for us. So let's talk about the rheumatologist cell. So I think the 2 hypotheses, and definitely have had some already productive discussions here, is that why is this happening? And so I think one is we have to think about the macrophage. And so remember, there's 2 kinds of macrophages in the body. There is what's called tissue-resident macrophages, and then there's your monocytes that go into the tissue in settings of inflammation and then mature into macrophages. Now, the tissue-resident macrophages don't come from the bone marrow, okay? They came from the yolk sac. So when we were tiny embryos and our embryonic layer started making cells, macrophages were made from the yolk sac. They went into the tissue and they self-replicate in the tissue, okay? So those aren't coming from the bone marrow. And so one of the concerns we have is that if you give chemotherapy, you can kill the bone marrow. So that garden you can get rid of pretty good. I don't know if there's a good analogy of hiding the macrophages, but maybe they're under a rock or something. I don't know. Anyway, but we don't really know what's happening in the tissue. Okay, so there's been some mouse study, and as it turns out, tissue-resident macrophages are pretty resistant, at least in the mouse, to chemotherapy and radiation, unless you do it really high. I'm not going to go through all these numbers, but essentially they gave these mice different degrees of chemotherapy and radiation. They did bronchs on them 5 weeks later, and even though almost all the T cells were from the donor, which are the spleen cells, if you look in the third column, which are the alveolar macrophages, if they got intense chemotherapy, the majority of them were replaced. But if they got kind of lower dose chemotherapy, which we often do for very sick patients, like patients with sJIA, they had a hard time replacing them. And again, this is in the congenic model, so this is not allogenic transplant, right? So these are basically, they're taking 2 mice which are genetically identical except for one small thing. So whether that can be recapitulated in the allogeneic setting is uncertain. All right, so just a summary of transplant and immune reconstitution. Again, multiple ways to look at the immune recovery and reconstitution, but really we want to combine modalities so we can maximize success and minimize deficiencies. For rare diseases, we really have to harmonize our evaluation, both pre and post-transplant, and so we can assess the therapeutic efficiency. Poor outcomes in JIA, at least that have been reported so far, are things that we can definitely associate with poor immune reconstitution: infectious disease, macrophage activation, and relapse disease. And I think we need to think, hopefully during these sessions, what are novel ways that we can look at this? Can we look at tissue-resident macrophages? Can we use the secretome for us to understand what the immune system is doing afterwards to do that? And so I think we need to really, as transplanters, expand beyond kind of our typical measures and understand that some of the disease-causing cells that happen in JIA might not be as amenable to being destroyed by our typical measures with conditioning therapy. So things like macrophages and actually plasma cells are also fairly resistant to chemotherapy. And so understanding of other things that we need to look at. And of course, I'm sure this is going to come up because it's come up already, is that what do we do with the HLA haplotype for these high-risk haplotypes? I do think that they potentially are also impacting outcomes in transplant.
Thank you.
All right.
So we next have Dr. Silva joining in via Zoom. So if we can bring her up and her slides. And after that, we'll have Dr. Sharat Chandra.
Hi, thank you so much for the invitation to talk on this very wonderful meeting, and apologies I couldn't be there in person this time, but hopefully next year I will be there. I'll join you in person. So I wanted to talk today a little bit about our long-term outcomes on the allogenic transplant for systemic sJIA. So you're very familiar with our previous publication on this group of 16 patients underwent allogenic transplant, and we had a median follow-up of 2 years on this paper. So we had 75% of them who achieved remission after allogenic transplant, and as Jim has already presented on his previous slides, there were a few patients who had autologous reconstitution remain in remission. Some of them relapsed and some that achieved partial remission only. So since then, we have been very interested in looking into what has happened to these patients long term. And these remissions that they went in initially, would they continue for many years after transplant? So that's what we have been looking in the past couple of years now. Many more centers have now also, send us the data from the patients. They have transplanted a few patients, and they are now long-term. So we now have 9 centers that have reported patients to us. The majority of them are from Marrow, but we have patients from Cincinnati, from Rebecca. We have also patients from MSK in New York. And as I said, the majority are from 3 centers in the UK, Paris, Prague, Poland as well. We have in total now 31 patients that have been transplanted from 2007 to 2022. The majority of these patients had systemic sJIA. They were transplanted quite late, I would say, and the majority have gone to a long list of immunosuppressive medications before coming to transplant, as you can see. The complications associated with sJIA that were the indication for transplant, the majority of patients was because of a macrophage activation syndrome. And the median follow-up on this study that we have is of 6 years, but it varies from 1 to 15 years. So the majority of these patients underwent a transplant from an unrelated donor. Most of them were fully matched donors, using, in the majority of patients, bone marrow as stem cell source. And all of them underwent a transplant using either reduced intensity or reduced toxicity conditioning. And initially, we were using more fludarabine melphalan compound. So this was the recipe that Rebecca spoke earlier. And more recently, because of concerns about mixed chimeras, patients that we have been using more fludarabine triosulfan and compounds. But there have been other variables of recipes of conditioning regimens as well, according to the centers. So this to me is the important slide, and this is to me what, it's very interesting to see, and I think it will be useful for discussion today. So what we observed then was 31 patients transplanted. They underwent allogenic transplant. And amongst these 31, so 5 of them died, and I will explain about these deaths in a second. But I will focus on the patients, obviously, that survived. So the majority of them, they had, they went into complete remission. There was one patient who went in partial remission. But amongst those patients who underwent in remission, we observed two groups of patients. Some that went into remission and continue in remission long term, and another group of patients who went into remission initially, but they relapsed. And then after they relapsed, they were treated again and achieved a second remission, let's say. But some had relapsed, were treated, and have ongoing active disease, still needing treatment for JIA. So when we look into this group of patients, what we did observe was, in terms of causes of death, unfortunately, this is not a side effects-free procedure. So patients died because of complications related to transplant, so either infections or thrombotic microangiopathy. But none of the patients died because of recurrence of the disease. So when we look into the relapses that I mentioned, I divided, and we could observe two groups of patients. One of them, the first one of them, were the patients who relapsed in the first year and a half, I would say, after transplant. And the majority of them had in common the same phenotype at the time of relapse, which was macrophage activation syndrome. What is interesting to note is that, some of them, as Jim has already showed us in his slides previously, was that some of them were 100% donor engrafted, but they still relapse. Some of them were high-level donor engraftment, and some had mixed chimerism and relapsed. They were treated, as I said, and those patients then went back into remission, apart from the last one that I showed in the last line, patient 24, that he lost his graft, had severe and refractory disease, and needed to undergo a second transplant to control the disease. But after the second transplant, he's in remission long term. Now, the second group of patients who relapsed after transplant that we observed in this cohort are patients who relapsed quite late, I would say. So as you can see here on this column, these patients relapsed many years after transplant, some of them being between 3 or 10 years after transplant. And what is interesting to note is that they also have in common the phenotype of relapse, which is more an arthritis phenotype rather than the systemic macrophage activation syndrome. And once again, I want to highlight that probably Jim has the answer now about the macrophages, because we can't really explain. It has been difficult to understand up until now why patients that were 100% donor grafted had a completely healthy and different immune system that they relapsed being 100% donor. Those patients, as you can see, needed a lot of treatment. Some of them needed a lot of treatment after transplant, but despite of needing treatment, some of those patients, they have an attenuated phenotype in comparison to the phenotype they had at the time they came for transplant. So the relapse phenotype seems to be milder in comparison to the phenotype when they were referred to transplant. So it is very hard because the number of patients is still quite small, and it's very hard to make any firm conclusions. This is just an observation that we made in this cohort of 31 patients. So what we did see was in 6 years, the overall survival was 84%. The majority of patients who died of complications related to transplant, they died in the first 18 months post-transplant. 60% of patients, they are in remission at the last follow-up, but there were group of patients that do relapse. In this cohort, was 42% of patients. Again, it's difficult to say in terms of percentages, but yes, it's 11 out of 26 patients did relapse. And then I would say half and half can achieve remission or can, unfortunately have active disease needing ongoing treatment with immunosuppressive therapy. As I said before, in terms of deaths, they are all related to transplant complications, and there was no JIA related deaths in this cohort. So again, I think, as we have been discussing this meeting during the day, I think allogenic stem cell transplant, it is an option for patients who have very refractory and complicated courses of JIA. It comes with, the risks of, mortality related to the transplant, as you know. I think there are now, our group has just published, team from Cincinnati led this publication, on the outcomes of patients transplanted with interstitial lung disease, and it seems quite promising. We have in these cohorts that I showed you, we have 5 patients, and all of them with complete resolution of the CT changes. They have been off oxygen and have improved significantly. So it seems to be promising. I would say it's still very early to say because the numbers are very small. And a very important discussion that I will be willing to do today is, in terms of and I will hear more about the other speakers, in terms of indications and what is the best timing for transplant. The timing may have a very big impact in terms of outcomes, in terms of reducing, transplant-related mortality, as well as also preventing some complications after transplant. I think, it's a good time for us to come up with a proper consensus, as Luciana said in her first talk today, a consensus statement in terms of indications and then the timing for transplant as well. I know that Paul Brogan has proposed as well this in the UK, but it will be good to have, an international consensus statement on this if we can. And then in terms of, what we need from here, it's obviously prospective studies. We should look into standardizing transplant recommendations, even conditioning regimens if possible. So it is a little bit easier to compare these patients. This cohort is not a genetic disease, so this cohort of patients is very different, and it's very difficult sometimes to compare the outcomes of so many different patients. So if we can reduce the variables, I think that will help. One question we do have, and we have been seeing more and more, the centers have been reporting to us, is that people have been continuing some biologic after transplant. So, for example, patients who had a very good response in terms of interstitial lung disease with a JAK inhibitor, then the transplanters have continued the JAK inhibitor for some time after transplant. A couple of months. Is difficult to say how long we should do that for. Should we really do that for? Is it necessary? But we have been hearing more and more this experience. Also, I think it would be good for us to discuss about some biomarkers. Again, as Jim was saying, perhaps IL-18, other biomarkers would be useful to assess disease response and predict when those patients are about to relapse. And I think one of the things that I'm also very interested in looking into is not only necessarily the joint or the number of medications the patients are on, but also into the quality of life of these patients, because the majority of these patients, even the ones who relapse, what I have seen in our cohort of patients, and also from reports in other centers, is that even though they did relapse, needed to go back on medications. Their quality of life, at least for some years, had improved significantly. And as the disease phenotype was attenuated, the quality of life was way better than what it was before transplant. So obviously this is anecdotal. We don't know until we carefully look into this, but it would be good, I think, to have a study looking into quality of life pre and post transplant, as well as, you know, other more objective measures of response. And I think in the future we'll probably hear some other therapies as well as CAR T cells, but it is very early days. So I think that is all I wanted to say today, but I will be very willing to discuss some of the points we brought up here on this panel. Thank you.
Oh, this one. Thank you. Hi, everyone. I'm Sharat Chandra. I'm a bone marrow transplant physician at Cincinnati Children's. I'd like to thank Rashmi and the organizers for inviting me. So I'll be talking on emerging transplant protocols for sJIA ILD. I have no disclosures. We know that Allogenic HSCT is successful in treating children with severe sJIA, and also considering that lung disease in sJIA patients appears to be immune-mediated, it's reasonable to hypothesize that allogenic transplant can improve pulmonary function in sJIA ILD and may also help reverse some parenchymal lung damage. So to answer this, Michael Matt, Daniel Drestov, Grant Schulert, and Rebecca Marsh looked at this outcomes of patients who underwent allogenic transplant for sJIA ILD. This was a multi-center retrospective study that included 9 centers. And these are the patient characteristics. So a total of 13 patients were enrolled. Most of them were female. The median age at diagnosis of ILD was around 5 years. The median age at transplant was 9 years. All children were refractory to 2 or more biologic medications, had worsening pulmonary function, or had complications from steroid dependence. Patients had received a median of at least 6 different agents prior to HCT. And the median follow-up was 16 months. Coming to the pulmonary characteristics, so all patients had the characteristic CT chest findings. 6 patients also underwent lung biopsy, and all biopsies had all biopsies had findings consistent with sJIA ILD. 5 patients also needed supplemental oxygen prior to HCT, and 6 patients had digital clubbing on exam prior to HCT. Now coming to the transplant characteristics, all patients received a reduced intensity and reduced toxicity conditioning regimen, and all of them also received serotherapy, primarily alemtuzumab. 6 patients had a 10 out of 10 HLA matched unrelated donor, and 5 patients had a 9 out of 10 mismatched unrelated donor. Bone marrow was the most commonly used stem cell source. Coming to engraftment and chimerism, all patients engrafted with 100%, greater than 95% donor chimerism at first measurement. One patient, though, after initial engraftment, developed secondary graft failure and needed a second transplant. 2 patients developed mixed chimerism, but they both maintained more than 85% donor chimerism in the T and myeloid cell lineages. Coming to transplant complications, 5 patients developed acute graft versus host disease, but there were no cases of chronic graft versus host disease. Infections were common, with 6 patients developing CMV reactivation, including 2 patients who developed CMV pneumonitis. Now coming to survival, so 9 out of 13 patients are surviving with a median follow-up of 16 months. So this is close to 70% survival, which is pretty good considering how sick these patients were at the time of BMT. 2 patients died of CMV pneumonitis, and 1 patient died of intracranial hemorrhage. This was in the setting of COVID-19 infection. And then 1 patient had continued progression of lung disease despite transplant and died around 1 year post-transplant. Coming to the sJIA outcomes. So most patients received some ongoing immune suppressive therapy for several months after transplant. 9 received steroids for a median of 6 months, and 3 patients continued to receive emapalumab infusions for a short period of time after transplant. And then post-transplant MAS occurred in 3 patients shortly after transplant, and then these patients were treated with emapalumab and cyclosporin. All 9 surviving patients eventually had complete response. They had no features of sJIA, and they were all able to come off immune suppressive medications. As you can see here, the ferritin, IL-18, and the CRP levels gradually improved in most surviving patients. Now coming to the pulmonary outcomes, so all 5 patients who were surviving, who needed supplemental oxygen prior to HCT, were able to come off oxygen. And then there was a trend towards improvement in pulmonary function studies as well. And 4 of 6 patients had notable improvement in clubbing as per exam. So post-transplant CT chest was available for 6 patients. 3 patients had notable improvement in chest CT findings, whereas 2 patients had stable chest CT findings on their CT chest. So now I'd like to discuss a T-cell depleted approach for sJIA ILD. So we know that there is an increased risk of non-infectious pulmonary complications post-transplant, which includes lung GVHD, idiopathic pneumonia, organizing pneumonia. Now, while these complications have multifactorial etiology, there is an alloreactive component to this. And we know that the risk of alloreactivity in GVHD is higher when you use a mismatched donor for transplant. Oh, sorry. So we know that alloreactivity is primarily driven by T cells. And so the idea behind T cell depletion is to reduce the risk of alloreactive complications. Now, there are some downsides with this approach. For one, there is a higher risk of graft rejection. And then there's also an increased risk of viral reactivation. Now, nowadays, this risk of viral reactivation can be reduced by the use of viral-specific T cells, which thankfully we have access to. So for T cell depletion, the graft can be manipulated to remove T cells, and this can be done either via CD34 selection or from TCR alpha-beta depletion. Especially in the setting of haploidentical transplant, we oftentimes will do post-transplant cyclophosphamide to deplete T cells. So 4 patients underwent T cell depleted transplant for refractory sJIA with ILD. And then all 4 patients received a reduced intensity conditioning regimen. The agents used are shown here. In terms of weaning off immune suppression, so we're still trying to learn what's the best way to do this. But in general, calcineurin and JAK inhibitors were stopped post-alemtuzumab, and then patients were transitioned to steroids during conditioning. In a patient getting anakinra was continued during conditioning until HCT. And then patients were also given emapalumab during conditioning. And the rationale was twofold. One was to prevent and reduce MAS flares. And then it was also given to facilitate engraftment. So this table shows patient and donor characteristics for the 4 patients. So the age at BMT ranged from 7 to 10 years. 3 patients were diagnosed with sJIA at a very young age, around 1 to 1.5 years of age. And the age of diagnosis of ILD ranged between 2 to 7 years. As you can see here, all 4 patients had very high IL-18 levels, ranging from 34,000 to 126,000. 2 patients received a 10 out of 10 matched unrelated donor graft, and 2 patients will receive a 9 out of 10 mismatched unrelated donor graft. For the first patient who got a 10 out of 10 matched unrelated donor graft, that patient developed secondary graft rejection. And so for the second transplant, received a haploidentical graft from his dad. So this was a 5 out of 10 match. So here you can see the CT chest findings from the 4 patients. And as you can see, all 4 patients had significant ILD and also had clubbing as well. This table shows transplant characteristics. So the first patient received a TCR alpha beta depleted graft, unfortunately developed graft rejection. And so for the second transplant, received post-transplant cyclophosphamide. This patient subsequently engrafted with 100% donor chimerism and has maintained his donor chimerism. The other 3 patients got a CD34 selected graft, and all 3 engrafted and have maintained 100% donor chimerism. The main complication in this cohort was, so one patient developed cerebral venous sinus thrombosis, which is an extremely rare complication, and we're still unclear as to the etiology. The patient had a extensive prothrombotic workup, which all came back negative. And then in all 4 patients, as you can see here, the IL-18 levels declined to near normal levels at last follow-up. Notably, none of the patients developed graft versus host disease. So all 4 patients are now clinically doing well. Patient 4, I'd say, is still 6 months post-transplant, but the others are 1 to 3 years post-transplant. They have improved lung function based on imaging and PFTs. There's also improvement in clubbing as well. None of the patients have developed an sJIA or MAS flare thus far. While the results are encouraging, we still need longer follow-up and more patients to know for sure if this is the right approach. So in conclusion, allogenic transplant can induce remission of the inflammatory features of sJIA. More critically, allotransplant can improve pulmonary function and can reverse chest CT findings in some patients. However, studies are needed to determine how to best stratify patients at highest risk of disease, morbidity and mortality for consideration for allotransplant. With this, I'd like to thank the audience. Thank you.
And now for Dr. Canna and Dr. Schulert, and they're not just going to present the perspectives from their centers, we've also asked them to gather perspectives from some other centers. If you both want to come up, I believe Dr. Schulert had sent us the last version of the slides, which are consolidated. So.
All right. Well, so Rashmi asked us to sort of think about what we would consider the criteria to consider bone marrow transplant for patients with difficult to treat. I like difficult to treat. Difficult to treat systemic JIA. And we kind of all independently came up with these, and so I think there will be a lot of overlap. So this is what I came up with. And so it's kind of one or more of these, and I think most of our patients who have transplanted check at least one of these boxes. I think certainly they have to fail to achieve a durable steroid-free remission to multiple classes of medications. Certainly IL-1 and IL-6 as our initial ones. Having a good trial of generally a broadly selective JAK inhibitor, so not just sort of the label poly-JIA dose of tofacitinib, but higher doses of more broadly selective ones. Generally having some sort of T-cell targeting therapy, such as a calcineurin inhibitor. And then the question of where MAS825, it's difficult to say that a non-FDA approved for anything medication should be a requirement to going towards bone marrow transplant. But I think it's certainly something to consider, given that there is availability for this for at least some patients through compassionate use. So it's at least going to be part of the conversation. I don't think they have to have tried that. And then progressive organ damage, really despite that therapy, that can be liver, that can be lung disease, that can be destructive joint disease. Recurrent episodes of overt life-threatening MAS, which again, prior to the last several years, as Juliana showed, was really the primary indication for transplant in these patients. They sort of phenotypically act like familial HLH patients. And then also people who maybe things are kind of being held at bay, but they're having really significant morbidity from their medications with really potentially life-altering side effects of growth failure, pathologic bone fractures, significant hypertension. And to what somebody had made the point of, should all patients be considered for bone marrow transplant? Maybe, or at least it should be discussed. So we've started actually over the last 6 months, sort of all of our new second or third or fourth opinion patients that we see. They see me, they see one of my pulmonary, or Dr. Gram, one of our pulmonary partners, and one of our transplant partners. And oftentimes we say, yeah, we're not ready for bone marrow transplant, but at least we can then have this conversation of, okay, well, maybe when would we maybe be ready to, and what would be our yardsticks of like, if we do this and this, it doesn't work, or if this thing gets worse. Just so we have that up front. It's a lot easier to have that conversation sometimes when they're not really sick than it is when they are really sick. So then, let's see. Is this advancing? Nay. There we go. So this was written by Mona and from our colleagues at University of Minnesota, who, again, a large and well-respected transplant center in the U.S. For rare diseases. Again, a very individualized discussion depending on that patient and what's going on with them. They've, again, yeah, as I said, if they're doing well and tolerating their therapies, that's generally not something that's being considered. But if they are refractory, recognizing that there is a window of opportunity where at some point there's going to be such significant organ dysfunction that the risks of transplant become much more significant. And then, is this you, Holly? Yeah. Do you want to?
Thanks, everyone. So Rashmi asked me to put some together for Boston Children's, but as you know, we like to spend months making algorithms, and so we haven't quite put together an algorithm yet for this. And so I kind of thought about the question from my perspective. I'm a rheumatologist, but I'm doing a transplant fellowship. I don't want to take up too much time, so I'll just go quickly. So I think in 2023, having reviewed our whole cohort of patients pretty much in a prior project, what struck me was that some children with lung disease could get better if you escalated their treatment. And so if we could just catch people early, maybe we could make a positive intervention. And so that's where the lung screening algorithm comes on. That's the left side of the top box. But then there are still children who we know that they might have a more severe course. We can predict that. We can try to escalate therapy, but then what we fear is happening, and it's just really difficult to treat. And so now that I'm in a transplant fellowship, we're starting to think more about early transplant referral. We don't have this fully defined, but I think recurrent flares, difficult to treat disease, progressive lung disease on therapy,
And then that would be our early referral to transplant, echoing what others have said, that transplant referral does not mean transplant. And at the bottom, I just wanted to highlight some of the potential advantages of having an early transplant referral. For one, you can create this collaborative care model between the transplant team, the primary teams, and patient families. You can achieve HLA typing to establish donor options that can inform a lot of the potential logistics of transplant. You can, again, check in and reassess at multiple time points. And then sometimes, as mentioned earlier by Lauren, there are some comorbidities that can also affect how we think about transplant, and it takes some time to refer to other specialists and really get a multidisciplinary input, and so that all takes time as well. As a last, I think really important component to this too is that all of our patients have lives, their families have lives, and transplantation is a long admission with a prolonged period of needing these frequent follow-ups, and often they're at like referral centers, and so like planning when you have the luxury of time, when that makes sense in a family's life, and if you can get some resources, can be really helpful. And so again, early referral might have a lot of benefits while still allowing some space to think about when is kind of the go time.
Great. And then Scott.
Yeah, so I don't think that I am a rainbow cake, but I kind of thought of this more in sort of the general kinds of questions that we try to answer. So the way that we review complex patients like this is within our immune dysregulation program, which is a sort of semi-formal, multidisciplinary inpatient outpatient program that includes rheumatology and immunology and oncology and transplant and infectious disease. And so we get the kind of groupthink on these folks pretty early. And so we feel like there's two decisions that we make. One is when to refer, and then when to proceed. And I think our transplanters are fairly deferential on both of those questions, and obviously not deferential on how to do the transplant. So like others, we have a low threshold for doing transplant. The parents find it valuable for all the reasons discussed, and we find it valuable because we can get the donor match options earlier. And then, I think at this point, we're nowhere near an algorithm for when to recommend proceeding with transplant. It's an individual decision. And obviously, I think we're all talking about allo transplant. I don't know that anybody's sort of revisited auto transplant. So I have one more. So the features that favor like early referral or early proceeding. So early organ involvement, we've talked a lot about lung, but there are other organ systems that matter. And so if really there's any, we try to do fastidious monitoring. We're trying to institute more sort of protocolized monitoring for these patients. But if there's any organ involvement early, that probably is a reason to sort of at least talk to our transplanters about whether they think they should see this kid. And then the second really is like, is there time to tinker? And I think that as rheumatologists, that's a lot of what we do is tinker. And I think that the discussion of what is maximizing medical therapy is beyond the scope of this, but is an unanswered question that Grant hinted on, I think, nicely. So certain organ failures can be a contraindication to transplant. And so if the lung disease is progressing in such a way that you don't have a 3 or 4 month period to get approval for and see if, whether it's MAS825 or whatever is going to work, well then for us, your answer is somewhat made that you have to sort of move to transplant because the risk that you're not going to be eligible is maybe greater. Likewise for infections, if in that interval that we're trying to tinker, another bad infection comes up that renders you ineligible. What is exhaustion medical therapy? And then obviously what families want is paramount. And I think as Holly said really nicely, we have to give them time to marinate on the decision and the logistics.
Great. I think that's the last slide. Yeah. All right. So I think
If
our
there's
panel.
anybody else from any other center who wants to discuss.
I just want to make a comment from the transplanter perspective and kind of echo, I think, what a lot of us are saying. I think as transplanters, these are really difficult diseases, and honestly, it's really hard for us to make that decision. I totally agree with Scott that we will definitely, at least in my practice, defer to rheumatology who know these diseases well. But kind of a look at it from this perspective is that if we don't see the patient before they're ready for transplant, the patient comes into my clinic, I don't know the family, and I don't have that therapeutic relation, and the first thing we have to say is, I'm going to take your child to a life-threatening procedure. Hi, I'm Dr. Connelly. And then I have to open the medical chart, and this patient has been sick for 6, 8, 10 years, and I have to go through that and try to understand what has worked, what has not worked, what are all the comorbidities that are there, and that's really hard. And so if we get to know the patients, we can build a therapeutic relationship. And I'm not going to make the decision if you're going to use tocilizumab. I don't want to get into that again. But I can see, like, when you gave this medicine, I can follow the response. I can see, okay, this is, and get a better understanding for the patient. It's just so valuable because these are hard diseases. And to transplant them, you have to understand the disease, which is going to be so individual to the patient. So that's why early referral, I think, is so key for successful transplant.
This is for Dr. Schulert, but could it really be for anyone? We've heard a lot about transplant right now, and how the mortality is still there, and there's a lot of pain and suffering that goes through the whole process, and a lot of time spent. And so, and maybe it's a last resort or whatever it is, but Grant, you put up some, try this, try this, try this, try this. Some of us, for diseases beyond systemic JIA, and I've done it for one child with systemic JIA who had horrific lung disease, use a combination of cyclophosphamide and rituximab, whether it's bad lupus or bad ANCA vasculitis, and my N of 1 who had horrific lung disease and MAS. Why is it we don't try that approach before we jump to transplant?
I mean, that's a great question. And I actually, a couple years ago, I was giving grand rounds and actually at Vanderbilt, and one of my old oncology attendings from when I was a resident, when I was talking about combining biologics, he's like, that's nothing compared to what we give to our patients. And also, maybe how much of our patients doing better after a transplant is the conditioning, knocking out that old immune system, and what doesn't matter what we give them. It's we gave them really aggressive therapy to control that inflammation. I don't know. Maybe we're not being aggressive enough.
I mean, because there's even data from Carol and David back in the day when we didn't have anything to treat bad systemic JA, and they were just getting cyclophosphamide. And it was a very small cohort, but those kids did well. So.
And I'll say, so I want to say two things about this, because this is a really important question. And the first is, like, that's your guys' job is, like, the rheumatology community to decide what treatments should really be tried before transplant, right? Like, that's not for us to decide. But what I will say is we have a lot of experience in patients with inborn errors of immunity where we do go down those paths and we do end up giving cyclophosphamide for CNS lymphoproliferation or vasculitis. And typically what happens is that still a few years later, we're still having these same sorts of problems. So I don't know how effective it would be, but if it's effective, absolutely you would want to save yourself going down that transplant path because of the mortality risk. Second thing I want to just say is that transplant is a lot different than 20 years ago or even 10 years ago because the reduced toxicity and reduced intensity types of regimens, they're just so much less risk. And I'm not saying that there's not risk, there's obvious risk. And there are patients that develop graft versus host disease or TMA or infectious complications and all those things. But I just want to highlight that it is a lot more gentle now. Most patients are in the hospital for, 3, 4, 5 weeks, including the conditioning regimen. And so just when I was a fellow going through transplant, we were still using fully myeloablative regimens. And so that transition to the types of approaches we have now, it's just some patients really do need very little supportive care during that period. And so just to draw that distinction between fully myeloablative transplant approaches and the way that things are approached in these children. So I just wanted to say that. And that's something that Rashmi mentioned to me that I meant to mention in my talk, but I didn't. So I wanted to say it now. So, and Rashmi, I don't know if you want to comment about the
Actually,
experience.
sample of one, but we went through 6 months of cyclophosphamide.
With rituximab? Or
Yes,
just like-
rituximab had a reaction, could not give the second infusion. So, I mean, yes, transplant was harsh, very harsh, but was it harsher than 8 months of sJIA, MAS, ILD, of the constant hospitalizations, of putting our lives on hold so that my other kid also didn't go to school so that we could save him from not getting infections? And ultimately, which is what saved him because his lungs were still in good enough condition that we could go through the transplant. So no, it was not worse than what we endured for 8 years. So I think you need to ask the parents who are living this life of like just constant medicines again after the one after the other. And I think help them be participant in that decision.
And natural history studies. I know there's like a big consortia grant that was just submitted to the RDCRN. Like you guys have the ability to really follow those outcomes for those patients, or just even doing some prospective treatment trials amongst yourselves. Like that's really the best way to try to answer this.
And I'll,
Of need.
Oh, yeah. Granny made a good point. I wanted to echo that as well as, you know, again, we tend to think of replacing the immune system as being the efficacious treatment here, but certainly they're getting profound immune suppression. And there's probably some correlation with, you know, there's certainly been cases of aplastic anemia who get transplanted and they have autologous recovery. And so there probably is, even though we talked about different recipes, and I totally agree with that point, you know, are there going to be certain immunosuppressive regimens where that's where we're getting our benefit? I did want to make the comment, you know, not to keep on defending transplant, but the outcomes that you guys presented are actually surprisingly good, in my opinion, given how sick these patients are. And, you know, we have to remember, I would assume that these patients that are coming to transplant are kind of the sickest of the sick. And so if we're already saying, like, these numbers are good enough that we should start really starting to consider it more, I mean, we would anticipate that if we can capture patients earlier before they have these severe outcomes, you know, that outcomes will even be better. And, you know, of course, one thing about transplant is that it's kind of a constant human learning, is that we need patients to learn how to do the process, not that that's a reason to bring them in. But I do think we want to make that point, is that we're really taking the most severe patients at the moment.
If I can just invoke one other thing, like I think the concept of opportunity cost is worth thinking about here, which is that the time during which we're tinkering is also a time in which we're not, anytime you pick one thing, you're not picking the other thing. And so as we're figuring out what maximizing non-transplant therapy is for our patient, for our institution, we've not chosen transplant, and we're exposing the patient to risks of further organ progression, bad infection, that kind of stuff. My personal experience, and of maybe 3, is that 6 months of Cytoxan sort of helped even things out for maybe another 3, and then we were sort of right back to where we were. And so I haven't given rituximab along with it. I haven't seen sort of the rationale and stills for that. But I think the outcomes are going to, you know, the other sort of old adage is like, it's like building nuclear power plants. The best time is always 5 years ago. And so the outcomes for transplant for systemic JA are going to look better as maybe things get more comfortable, because we're going to be referring patients who are maybe not as direly ill. And so their transplant outcomes are likely to be a bit better. I don't know if the transplanters would agree with that, but it always seems like by the time the decision to transplant becomes clear, it's always, you know, we wish we had made this decision 5 years ago. But for every one of those patients, there's a patient that we actually have managed to get under better control.
Yes, just as a parent that's going through this process right now, I mean, what advice does rheumatology and the BMT team have for us to try to close this gap? Because I feel like we've got support on the rheumatology side, you know, of this, but we don't necessarily have full-blown support on the BMT side. So how do we work through this process? Because it has been a long 12 years, and watching what our daughter's going through every day. So how do we close this gap? And is whose voice is, I guess, going to get to be the loudest?
So this is incredibly challenging, and none of us know what it's like to go through this as a parent. And I would say that what typically is able to get to a decision with everyone being comfortable is that shared over time decision-making for patients with your different care providers. So having your BMT physician and your rheumatologist and whoever else is involved in the care really being in that communication phase over time, because it tends to be sort of a consensus-generated decision in the end, and you are absolutely at the table for that decision, and you actually carry the brunt of it. And our job is really to support you in that process as much as we can. And I would say leaning on other parents and getting advice and learning and getting mentoring through that experience from other parents is also very helpful. And Rashmi, I don't know if you or the other parents want to give advice about this. You know better than we do. Fair. So it's really, and sometimes you need to voice up, can we have a shared meeting all together where you're all in the same room together and you have shared conversations? Because sometimes everyone's busy and you're sort of seeing people independently and hearing different things. And so sometimes just asking for, some hospitals call it a care conference, some hospitals call it other things, but just asking, can we get everyone in the same room to have an hour together where the focus is really just on thinking about this all together?
I'll say that it's a little bit simpler for us where that conversation, like every Friday at 11, we have our conference and we have ONC and we have usually transplant. And so, the transplant team is sort of part of the discussion before actually transplant even comes up, because they're kind of vaguely aware that there's a patient that's been hard to manage anyway. And so I think that just however institutions are going to do it, transplant teams probably need to be part of the conversation of refractory systemic sJIA earlier than they have been. I think that that's a process that is sort of catching, but that this conference is probably doing a lot to push forward.
I think our friend online would like to speak.
Oh, Dr. Silva?
You're muted.
Yeah, we still can't hear you, sorry. We're working on it.
Can you try?
No.
1 second. It's okay. That was me. If you want to write it in the chat, we can read it.
While we're waiting, could I ask another thoughtful question for you?
Please.
Since we're talking about emerging therapies and new things to come, someone mentioned CAR T therapy, and could you talk about what the future holds for CAR T cell therapy and transplant, and/or transplant?
That's a Holly question.
Oh.
You only get one sentence.
Oh dear, I don't know if that's a one-sentence question. I think actually Dr. Silva brought up CAR T. I think about CAR T in different settings where, for example, it seems so far that targeting B cells are a reasonable target for lupus, and for some other B cell mediated disorders. I don't know what the target would be for systemic sJIA, although that's something that I've started to think about a little bit. And I think there was some very interesting presentations earlier, also discussing like some of the tissue resident cells that contribute to relapse after transplant. And so something that I'm also thinking of is like, would CAR T cells get that population? Because if they don't, would that similarly suggest that it could come back? So I would actually be curious to hear what some of the BMT physicians here are thinking about this in terms of, you know, potential application.
Well, that's a tough one. I mean, I think we can learn from what we've understand from the CD19 CAR therapy. You know, I think part of it is identifying the right target, right? And so that is incredibly important. And sorry for any of the B cell people out there, but you can live without B cells. And so, you know, some of the things that, you know, given that, you know, systemic JIA, it is such a kind of broad immune dysregulation problem. I mean, if you just took out a particular, maybe not all the macrophages, but maybe if you took out, you know, a certain pro-inflammatory macrophages, if you could even get that intricately targeted, you know, it's hard to believe that you would eliminate the disease. And I think if you picked a broader target, again, is that going to put the patient at such high risk, you know, for, you know, kind of infections and later complications? You know, I think that's the hard part, right? And how long would that process happen? I think certainly I think there's the potential because as I think you're exactly right, is that one of the advantages of CAR T is, you know, at least from what we understand in the leukemia world, it gets into the CNS, it gets into areas that are fairly protected, you know, from drugs. But immunological therapy has the ability to kind of do that. But I think it's an incredible technology. I think it gets a little bit more difficult once you are speaking about more broadly impacted immune disorders.
Jim, do your socks have immature neutrophils on them and say, I'm with the band?
That's an easy question, yes. These are, immature neutrophils are called bands. So, you know, hematologists can rock the socks as well as
That's a good hematologist.
Can I read Dr. Silva? So I have two comments from Zoom. So from Dr. Silva is I just wanted to make a comment that is, I am also a bit concerned about these relapses. I think we do need to investigate further the causes and how we can prevent this in the future. Perhaps myeloablative, I don't know if this is right, but reduced toxicity conditioning, but something else as well. And then I also have a comment from a patient. As a patient who has experienced transplant and relapsed, what evidence have you seen for a second or tandem transplant? Does n equals 0 in this scenario, or does a precedent exist? So this is Alan Kaiser, who is a patient.
I'm sorry, if you don't mind, can you repeat the last part of the...
Yeah, what she's asking is, like, she relapsed, so there's, like, is another transplant possible? So...
Yes, so I think, yes, for sure, another transplant is possible. Like, you know, for one of our patients didn't relapse, but did undergo graft rejection, and we performed a second transplant. And following the second transplant, that patient did well and has stayed in remission.
And I'll just qualify that a little bit, that if it depends on the reason for the relapse. So if this is someone that's maintained 100% donor chimerism from their donor, and now they've experienced relapse several years later, the thought for the second transplant would simply be to allow very high intensity immune suppression to be given, essentially, so that you could have like an autologous rescue, sort of like is sometimes done in the cancer space, just allowing you to give really intensive therapy and then giving stem cells back for that person to recover. So in that setting, we probably wouldn't do like an allogeneic transplant from another donor. And you probably wouldn't do an autologous transplant either, even though that would potentially be a possibility if the disease was so severe and refractory for some reason. But in those cases, you really might be just trying to intensify therapy unless you really felt like you needed some sort of autologous rescue, autologous transplant type of therapy. So it depends for the reason on the relapse.
And sort of related to that, I'm very intrigued by Dr. Silva's data on the patients who relapsed and how they relapsed. And there was really arthritis really as predominant, and it gets to this sort of idea more broadly in JIA about sort of joint-specific memory. And I'm sort of want to know, like, did they have arthritis before this, and were they relapsing in the same joints that they originally were involved in? She's shaking her head. So new joints, or which is really interesting, right? And that gets to this idea of maybe there is some sort of a target that's not getting completely replaced, or something in the joints that is persisting just after the bone marrow itself has been replaced.
Right, because you won't fix that again
Right.
a second time if it's something resident.
Right, for the same reason we won't do a bone marrow transplant if there's significant sort of organ cell, it's not just an immune-mediated disease, right?
Does 100% peripheral chimerism necessarily mean that the tissue compartments are so 100% donor?
So immune hematopoietic-derived cells that have been created since your transplant, yes. But resident macrophages or tissues that are not replaced with a transplant, no. So for instance, an XIP deficiency, you don't replace GI tissue. That disease still gets better because it's immune-driven. But there are other immune disorders like TTC7A, where the GI tissue is intrinsically defective as well. So even though you replace the immune system and the immune deficiencies get better, the GI disease is just as bad as it was before.
But I'm speaking about immune cells, right? Like, when you can lethally irradiate experimental systems and look in the tissues to see, the blood may be 100% donor, but the macrophages or the tissue resident T cells may not be. Has that been experienced?
That has not been looked at in sJIA as far as I know. So this is a great study for all of the consortia study through the RDCRN is to collect tissues and do staining and look at that type of thing.
But even in other diseases, like in the...
No, you would think that would be, again, I think for the majority of diseases, that have been traditionally transplanted, i.e. cancer, is that the peripheral blood chimerism has been very sensitive for detecting relapse, like even better than actually getting bone marrow. Because often when you get bone marrow, there is some impurity to the sample. So if you get a little bit of recipient cells, it might be because, there are going to be some mesenchymal stem cells that are left over from the recipient. So in fact, a lot of the chimerism studies have shown that peripheral blood is definitely predictive of relapse. But in these disorders where, we don't have a bone marrow derived disease, specifically, yes, that's where some of the immune system is, but, understanding what's in the tissue has not been looked at. These patients aren't getting biopsies. They might be getting GI biopsies is probably the only thing that would be commonly done.
Dr. Silva promised she was going to get synovial biopsies.
There you go. That's a beautiful study.
Isn't it?
Yeah, it is.
And online, there was a question about how does trisomy 21 factor into your transplant decision-making?
So I would say it is certainly very difficult to transplant patients with trisomy 21, even outside of sJIA. And in general, we would adopt a reduced intensity regimen just to minimize toxicity. And I should also mention that one of the patients who died in the earlier study was actually a trisomy 21 patient. So bottom line, yes, so they're certainly much more challenging to transplant.
He can ask. I'm not moderating.
I was going to ask about the lymph nodes earlier when we were talking about the obliteration of the immune cells. I had read a paper that was talking about how in the absence of the most intense ablative therapies, you do have the possibility of some residual cells in the lymph nodes. And I'm thinking about Still's disease where we have giant lymph nodes in these inflamed patients, and that's where the trouble is, right? But it sounds like we have a study that's potentially going to look at those lymph nodes as well, so that's really interesting. My other question gets back to the thing that I think a little bit about HLA-DRB115, and we talked about this a little bit, but I'm wondering what percentage of the patients that have been transplanted to date were HLA-DRB115 positive? How many of those people got a DRB115 matched donor? And then of those, how many of those had relapse of the articular or other varieties?
So in our paper, I think about 2/3, 70% of them were DRB1*15 positive. They all had essentially the same combination, like the heterozygotes got a heterozygote match because they were almost all 10 out of 10 matches. And there was no difference in relapse.
Did they have the whole DR15 ancestral haplotype all the way to HLA-B?
I mean, that sounds like a Mike Umbrella question that I don't know, but
I'll have to look at your paper.
Yeah, we should look at that.
Yeah, we have to look at that, yeah, sorry.
We've got the data.
Yeah, we had kind of talked about this, is that, I think we as transplanters have underappreciated the effect of donor genotype and phenotype, not just in this disorder, but in transplant in general. And the way that I kind of, as we were talking earlier, is that, a lot of time as the transplanters say, well, the parent has the same, high-risk haplotype, but they're fine, or the brother or sister. But then you have to realize what we're doing with that genetic haplotype. So we are now taking an immune system that developed in utero in a sterile environment, and then now putting it into a heavily damaged patient that is going to be bombarded with infection, with inflammation, with a lot of pathogen-associated molecular patterns, damage associated. So basically, we are now taking a high-risk haplotype and putting it into war. And so to think that just because the donor is fine and putting into this incredible war zone where now you have to rebuild the immune system, I think is a little bit naive. So it's a fantastic question. I think we have to understand exactly what that haplotype is now going to be doing in the immune reconstitution state.
And sort of related to that, in a disease that has at least some, if not a lot of genetic basis, how do we feel about a sibling donor? When we don't know what the genetic contribution of this disease is. I know Rebecca and I think about this a lot. And so I'm interested in other thoughts from both Jim, but also the other folks in the room who've had patients who've gone through transplant.
And just before people answer, I think that's a very important question also because, from a transplant standpoint, the outcomes with a matched sibling donor transplant are really quite favorable. And I actually did transplant a patient with a matched sibling donor, and luckily that patient's doing fine. But that patient literally sailed through transplant without any problems because, as you can imagine, the risk of alloreactivity is much less with a matched sibling donor. So I think there needs to be a really compelling reason to not do a matched sibling donor transplant.
Yeah, I just learned a lot. I want to know, are there some research or maybe study compare with no transplantation, the match, the patient about the result? How about the death and the relapse, flare-up, and also the outcome? So I want to know the benefit with no transplantation. Risk and also, thank you.
I'm sorry.
So the question is, this is our FDA question, right? Is what's the placebo, right? What's the control group, right? And so depending on the study, again, just thinking about specifically for lung disease, the initial cohort had a mortality rate that approached 50%. More recently, it's been certainly 10%. And that's just death and putting aside all these other, quality of life and growth effects and steroid toxicity and other things. And that's why it's not first-line therapy, right? Is because many of them, not everybody's the right patient for it. But yeah, that's a great question, because what's the alternative?
Yeah, I think that's well put. And we all do non-malignant transplant, and we're rarely going to win the survival game, the short term, I should say. which is where, a lot when we're trying to publish papers or get, procedures or drugs approved, that's kind of what we look at. And so I think it's critical as we think about this and how we are looking at patients is understanding kind of what are the other valuable endpoints that we need to look for in these patients, both kind of short and long term. And I think, as been mentioned several times, is having a very kind of regimented way that we look at these patients, both transplanted and non-transplanted, in these natural histories, so then we can make those comparisons. And I think the hard part is, which has been mentioned several times, is this disease is so incredibly variable. Like, is there really a control group to the transplant group? That's just really difficult to do, I think.
And,
With that,
if I can, if I can ask the rheumatology folks, so in terms of with families with sJIA, do you see other siblings also develop sJIA, or is it
Very rarely. Very rarely. We had one pair of siblings in 30 plus years at Cincinnati who it turns out have HIDs, once we figured out HIDs. Yeah. Almost never, unless they have a true monogenic disease. Paul, I saw you nodding.
If you've got siblings, you've probably got the diagnosis wrong, and there's a monogenetic disease there, mimicking Still's disease. Which is why, if you are considering using a sibling, it's reassuring to have whole exome data on your patient and your sibling, just to make sure.
Sure.
Yeah, true.
Absolutely, absolutely, yes.
True.
And we
I think all these
generally
patients
do
probably
that.
should have whole exome, absolutely, before they go to.
Can I ask a question on that? So,
We're blowing past the stop sign.
just curious, because it's a great question. Great, whoever brought that up. Great question. So, obviously we know that there's a lot of, we know that genetic testing is nowhere nearly as sensitive as we'd hope would be at this point. For these IL-18opathies, I don't know if you guys like that term or not, should we also be checking IL-18 levels in the siblings if we know it's high in the the recipient?
Yes, and we do check IL-18 levels in our potential sibling donors. Yes.
Okay, thank you so much.